Good afternoon, everyone. My name is Ajayi. I am a medical microbiologist with SHA, based here in Regina General Hospital, also covering RRPL. And I came to Canada last year, that was July. Prior to then, I'd worked in the UK for 13 years and as a medical microbiologist for 6 years prior to coming over. So today I will be sharing my experience with antimicrobial stewardship during the first wave of COVID-19 in the UK. So I'm just going to share my slides. Can you see my slides?
Yes, we can.
Okay. So the first wave of COVID-19 in the UK was from March 2020 to May 2020. And the second wave was roughly around September 2020 to January 2021, which was at the peak, but it finally ended. The second wave ended in April 2021. So just bear this timing in mind as we go through the presentation. So what we'll cover today, I first of all like to start by talking about where we were at the end of the first wave, both locally as well as beyond, in other parts of the world. And then University Hospitals of North Midlands approved during the first wave. So that was the hospital where I was based, and it's over 1,000-bed teaching hospital, specialist hospital, which has complex case mix, including neurosurgery, and it's also a major trauma center in the Midlands in the UK, England. And then we'll conclude by looking at where we are going in the second wave of COVID. So these are the things that sort of informed our actions during the pandemic. So this was a publication in the CID, which tried to estimate in terms of, how frequent we have cases of bacterial or fungal co-infections in individuals diagnosed with COVID infection. And you find out that with the conclusion, you can see that generally the frequency or these COVID infection was only infrequently associated with bacterial and fungal infections, which constitutes roughly about 6%. And then you can have, and the most surprising thing was that despite the infrequent association with secondary with co-infections, there was very high frequency of usage of broad-spectrum empirical antibiotics. Also, there was another article, which is a US preprint. Also, that's also looking at co-infection in cases of COVID, and you can find that it's very low, of only about 3.5% of patients with COVID-19 are confirmed co-infections. So co-infections are essentially community-acquired pneumonia coexisting with COVID. Despite that, empiric antibacterial use varied from 27% to as much as 84% of cases. And it was found to be highly associated with those who had severe illness or had a lower infiltrate or were admitted to a for-profit hospital. So this is a CMI article. The authors are UK authors, and it essentially looks at the prevalence of bacterial and fungal co-infections within 2 London hospitals. So it's a retrospective case series looking at co-infection. And this also found, you can see that there was a low frequency of bacterial co-infection in early COVID-19 hospital presentation, and no evidence at all of concomitant fungal infection, at least in the early phase of COVID-19. And here we have the JAC, Journal of Antimicrobial Chemotherapy, which did a sort of international survey looking at both co-infection, which is infection at presentation with COVID, as well as super-infection, which is secondary bacterial infection. These are usually acquired as sort of nosocomial infection following admission. The survey was quite extensive, and it involved about 166 participants from about over 23 countries in 82 different hospitals. And you can find that the study revealed widespread broad-spectrum antibiotic use in patients with COVID-19. Interesting to note that antibiotic use treatment ranges from up to 5 to 10 days of therapy. So here is the breakdown. So if you look at the first survey question, it says, do you routinely prescribe antibiotics to patients in the ward? So you can see that for most European countries, they do not, whereas you have a high case is in North America, where you have lots of routine prescription of antibiotics. And if you look at the breakdown of the antibiotics for Europe, as well as so for North America, it's more of ceftriaxone and macrolides, whereas for the UK and European countries, you have more of non-pseudomonal beta-lactam and beta-lactamase inhibitor in combination with a macrolide. So this tends to be the empiric therapy for those admitted to the ward, whereas for those who are admitted to ICU in the UK and other European countries, you get more piperacillin tazobactam usage, as opposed to in North America, where you have more of vancomycin, cefepime combination, or ceftriaxone as azithromycin, or with cefepime, vancomycin, or linezolid combination. In most North American countries, this includes US and Canada. So this is another study from Dublin, looking only at co-infection, and the patient groups were divided into non-severe as well as severe. And you can see that even in the non-severe cases, most of the patients did receive antimicrobial, including one patient who had an antifungal given. And treatment duration, interestingly as well, surprisingly as well, for non-severe, ranged to as long as 14 days of antimicrobial therapy. And here there's a retrospective report published in the CID, also looking at co-infection only. And that also reports infrequent co-infection rates of to 3.7% of patients. However, they found that patients who were admitted to ICU had up to about 40% of cases tend to have a co-infection. But regardless, the overall co-infection rate being low, up to about 70% of patients still received antibiotic. And if you look at the table, interestingly, for bacterial co-infection, it's only 2.2%. And then this publication in the CMI by Canadian researchers, which is a meta-analysis. This looks at both co-infection as well as superinfection, which is secondary bacterial infection. It's quite an extensive number of studies of up to 1,300 studies were screened, even though only 24 were eligible. And this represents well over 3,000 patients with COVID infection. And then you find that bacterial infection was, so they found that in the meta-analysis, bacterial co-infection was identified only in 3.5% of patients, while superinfection was found in roughly about 14%. And bacterial infection was more common in critically ill, but even then it was less than 10%, only about 8%. And despite this, the majority of patients with COVID-19 received antibiotics, almost about 72% of cases. And then this is a Scottish study which looked at the it's a survey of antimicrobials prescribed for patients with suspected and confirmed COVID-19 infection. And the highlight of it in terms of a summary is that they found that antibiotic was prescribed in 38% of patients with SARS with COVID-19, whether they were in the ward or in the critical care areas. Most of the antibiotics were narrow spectrum antibiotics, predominantly in the ward, which reflected the national recommendations. As we'll come to that later. Broad spectrum antibiotics and antifungal in critical care indicative of suspected nosocomial bacterial fungal infections. And they found that patients who had nosocomial COVID-19 or are diabetic or elderly tend to have a lower chance of having antibiotic prescribed. So with this background, we look at our approach during the first wave of COVID-19, which, as I said earlier on, is from March to May, to the end of May in 2020. So the first thing we did was to update our local antimicrobial guidelines in light of the recent publication from the NICE guidelines. So this is a national guidance that informs clinical practice guidelines. So you can see the modification says clearly it's an interim supplementary guidance to provide a local adaptation of recent NICE guidelines. And we also emphasize that routine use of antibiotics and novel agents for treatment of COVID-19 is not supported without specific consultation with either microbiology or infectious diseases. So the criteria were there, and then also emphasized in terms of duration for patients who required antimicrobial therapy to consider giving only 5 days of therapy and stop unless there's a clear indication to continue. So this is the NICE rapid guidelines. So NICE is the National Institute for Health and Care Excellence in the UK. And it was published around that time in May 2020. So then it talks about what you need to consider before initiating antibiotics, when to start the antibiotics, as well as the choice of empiric antibiotics to commence. So for moderate to severe pneumonia, the first line was amoxicillin clavulanate or doxycycline, or you could combine amoxicillin clavulanate with clarithromycin if you're suspecting atypical infection, especially. But if they had severe pneumonia, then levofloxacin will be an option. And for those requiring intravenous therapy, those are the recommendations. At that time, our guideline was this, because we used more of amoxicillin as empiric therapy. So existing guidance at that time was different, and we reserve amoxiclav and doxycycline for severe, as well as levofloxacin for severe pneumonia. And if you were suspecting MRSA infection, you would then add in vancomycin in addition to that. So looking at our antibiotic utilization at the University Hospitals of North Midlands, reporting by defined daily dosage, DDD. So you can see that at the start of the first wave of COVID-19, there was a marked reduction in antimicrobial usage. So essentially, we focused on empiric therapy for community-acquired pneumonia based on the NICE guidance, which is amoxicillin clavulanate, as well as doxycycline and clarithromycin. So for all three antibiotics, there was a decline, but it was more marked for amoxicillin clavulanate as well as for doxycycline. You can then see as we approach towards the end of the first wave, there's a gradual increase approaching towards the baseline, but the decline was sustained for clarithromycin. Interesting to note, around this time of significant decline in utilization was when national lockdown was initiated in the UK. So we feel this is more related to that as opposed to a systemic change in prescriber behavior. So this is also looking at the breakdown of his antibiotic usage from January to June 2020, searching. So you can actually select based on antibiotics, as well as the month and the hospital site itself. So you can see here that high usage of respiratory antibiotics were more in the respiratory ward. And also, interestingly, we found in the surgical assessment unit and emergency surgical unit, there was high usage. So this informed antimicrobial stewardship around to wards with high usage, where stewardship interventions are then targeted. So this is not directly related to COVID, but I just want to give a broad overview in terms of monitoring as well as reporting of antimicrobial utilization in the UK context. So this is reported under SEQUIN being Commissioning for Quality and Innovation. So there are 13 national quality indicators, and antimicrobial utilization reporting falls under quality indicator number 2, which is reducing the impact of serious infection, including antimicrobial resistance and sepsis. So under the reducing the impact of serious infections, and then you have the goal of which is timely identification and treatment for sepsis, and a reduction of clinically inappropriate antibiotic prescription and consumption. So this is the adapted WHO aware list for England, which divides the antibiotics into access, watch, as well as reserve category of antibiotics. So essentially what is expected, required by NHS England is to increase usage of access group of antibiotics while you reduce the utilization for both watch and reserve category of antibiotics. So this is an example chart showing the data for 2016 to 2019. So this data are DDD per 1,000 admissions. So these are routinely collected and submitted nationally every quarter. And the target is set as the median hospital utilization based on case mix. So for example, the target for specialist hospital is different from that for teaching hospital, which is different from that of non-teaching hospital. And having had your target, then you now have the threshold that is set. So for example, here, we are required to meet, to deliver a 2% reduction in the antibiotic utilization for the following year, since we've hit the target, the threshold of 2% reduction threshold. And then for the carbapenems, here we did very well. So you can see we are well below the target. And this is linked to financial incentive payments as well. So as a result of this, we do get senior buy-in, even up to the level of the medical director. And the last thing that is assessed is the utilization for aware access category of antibiotics. So here you can see that we're doing well and heading towards the target of 55% access category of antibiotics. So for the second wave, what we did was then to reflect on the recently the 2020 WHO bulletin, which highlights sort of 5 measures of how to incorporate antimicrobial stewardship program into the ongoing pandemic. So this is a summary of the 5 measures. Increase clinical competence among health workers treating COVID-19, ensure continuity of essential health services, reduce the turnaround time for COVID-19 testing, exercise caution in the use of biocides for the environment as well as for personal use, and to address gaps in research to ensure that antimicrobial stewardship activities become an integral part of the pandemic response and beyond. So we focus more on the first as well as the 5th one. At this time as well, we're having consultations from intensivists about concerns about increased incidence of Kappa, which is COVID-associated pulmonary aspergillosis. So we have to sort of decide and consult in terms of, appropriate diagnostic criteria, both microbiology-wise, imaging, as well as biomarkers to establish this diagnosis. This was before the landmark Lancet publication, which followed the following year, where we now have established criteria for possible, probable, as well as proven kappa. So it's a note of thanks to my colleagues in UHNM as well as to the antimicrobial pharmacist. Thank you.
Thank you very much, Dr. Ajayi. I'm just